Hi everyone, I'm Dr. Peter Malliaras. I'm a tendon researcher and physiotherapist working at Monash Uni in a clinic in Melbourne. Very happy to be on the podcast with Brad.
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Listeners, welcome to another episode of the Physical Performance Show. I trust you've been having a great week, and I hope that you have been kicking some physical goals with your own performance. If you have, let me know. I'd love it if you drop me a message over on social to let me know what you're training for, or you are getting ready to attack in some way. So be sure to let me know. Interaction is wonderful and I really appreciate and always enjoy hearing from you, the faithful listener of this program. Today's show, listeners, is lovingly brought to you as always by POGO Physio. We exist to help you perform at your physical best, and we do this through our industry first fixed fee and unlimited access 2, 6 and 12 week finish line programs. These are industry first ways of offering physiotherapy to active people who want to perform at their physical best. And now what's unique about the finish line programs is that you get the treatment as a consumer that you would truly benefit from, as opposed to the treatment that you can generally afford on a session-to-session basis. So gone are the days of coming once a week for 6 old weeks. Rather, if we can accelerate that with something like our 2-week finish line fast track program, then that's what we'll do. Typically our 2-week fast trackers are on the treatment table every day of the week, and they are also getting some remedial massage to help them along. Our 6 and 12 week finish line programs, they include active rehabilitation, so that's unlimited access to things like clinical Pilates, whole body vibration therapy, and Alter G anti-gravity treadmill running, state-of-the-art equipment. And they also include unlimited access to, of course, hands-on physiotherapy. So the same thing, if you need to be on the treatment table every day to ensure you get back to doing what you love at your physical best as soon as possible, then that's what we do for you, all at one fixed fee. On the 6 and 12 week programs, you'll also get access to remedial massage and podiatry. So if you're looking to truly cross your physio finish line, get that high five moment where you get told by your therapist, we love you but don't come back, unless of course it's for maintenance or optimization of performance, then check out POGO Physio's finish line programs. Jump over to pogophysio.com.au and look out for us coming to states outside of Queensland in the coming months as we launch our POGO Partners program through Australia. Massive thank you to you, the faithful listener, who is tuning into this program. The amount of feedback I've been getting, the taps on the shoulder, is really quite sensational. It certainly brings me a lot of joy. And thanks in particular to the listeners who have been jumping over to iTunes and leaving reviews. I really appreciate it. It helps this show get more visible, is not the right word, but more in the earbuds of fellow peak performers and people who are interested in performance just like yourself. A massive thank you to Dr. Ames, who recently rated the program 5 stars and commented, mentally inspiring my physical performance. Comments were from Dr. Ames, I'm starting to figure out my greatest challenge is not my body, but my head. As the great marathoner Eliud says, and that's obviously Eliud Kipchoge, It's your mind you have to convince to do great things. This show is inspiring beyond belief. I love the variety of the people interviewed and Brad's casual questioning of what makes them tick. This sure makes effective use of my pre and post training car trips. Thank you. Dr. Ames, thank you. Thanks for taking the time to leave that review. That's rocket fuel to me in bringing the guests to you, the listeners, so really appreciate it. And listeners, if you're listening in, you've been thinking about leaving a review, please jump over and do it. It really does help rate this higher in iTunes and, as I said, get in the earbuds of more fellow peak performers. It's real simple. You just jump over to a desktop computer, look for iTunes. If it's an Apple Mac, it's right there at the bottom of the browser. And click, find the program, the Physical Performance Show, click ratings and review and rate away. 1 star if it's okay, 5 stars if you've really been enjoying it and taking something out of it. I hope you enjoyed last week's guest, Mr. Aaron Royal, Australian Olympic triathlete, who shared around his journey of dreaming of Olympic representation and then consummating that dream in the 2016 Rio Olympic Games where he debuted. And his race didn't go exactly to plan, but it was still a very solid outing. And Aaron takes us through the journey of qualifying for the Olympics and then what was going through his head on the start line of his first Olympic Games, through the highs and the lows and getting started on his triathlon journey. So you really enjoy that, particularly for a triathlete. Be sure to jump back and tune into episode 61 of the Physical Performance Show. Today's guest, as I mentioned at the outro of last week's episode, is the show's first expert, the Physical Performance Show's first expert. And I have had the distinct pleasure of catching up and bringing to you an interview with Dr. Peter Malliaras. Peter Malliaras is, as a physiotherapist, someone that I really look to. He is a specialist tendon physiotherapist and also the Associate Professor at Monash University. Peter's specialisation in practice involves the management of patients with long-term tendon pain, tendinopathy, or in days of old, tendinitis, if you like. Peter's also a physiotherapist from operating out of Complete Sports Care in Melbourne, Victoria. Beyond Peter's expertise as a therapist, he's got an innate ability to break down the literature and the research of which he's heavily involved in and bring it to healthcare consumers, or in my case, physiotherapists, who other allied health practitioners, who really need the level of expertise that he can bring and garner out of the research to put into practical terms. And that's what I believe you're going to really get out of today, listeners. If you're someone that's had a niggly, persistent Achilles tendon pain, for example, or that troublesome knee tendon pain, the Patellar Tendon, or that pain sitting down on your bottom there from a proximal hamstring tendon, or even to a degree plantar fasciitis, you know just how pesky tendon pain can be. And I want to encourage you to take a pen and paper and write down some of the key practical bits of advice that Peter dispels through this interview, our time together. We cover everything from what tendon pain actually is through to what's often missing in people's rehabilitation as they attempt to get their tendon pain rehabilitated. We cover Peter's opinions around shockwave therapy, anti-inflammatories, imaging in terms of tendons, diagnosis, and a whole bunch of other great practical things that I know you're going to be able to go and apply straight away. And I want to charge you at the start of this interview, if you do know someone that's struggling with a tendon injury that's keeping them sidelined and away from doing the physical things that they love to do, then please pass this on to them, share the link with them, and allow them to take some of the great learnings that we'll receive today from Dr. Peter Malliaras. So let's jump straight in, Dr. Peter Malliaras. Peter, I've been looking forward to catching up with you for some time, ever since I was one of the physios that went through your excellent Mastering the Lower Limb Tendinopathy course in Queensland last year. And so I know we've had a few chances to try and catch up, and we've finally snagged one. I know you've been busy writing applications for research grants, but mate, really looking forward to today, a bit of deconstruction, if you like, of the world of lower limb tendons for the listeners. So thanks for jumping on.
No worries at all, Brad. Sounds Sounds good to me. Sounds good.
Pete, I just want a little bit about yourself first. What's your fascination with tendons? What's your story? How did you end up devoting so much time into the wonderful world of tendons?
Yeah, well, look, I just think for me it was right place at the right time. I've been lucky to work with some very good people, and that was really the spark for my interest in tendons, and it's very much grown after that. I think my wife is very upset with me because ever since I did my PhD, she reckons I haven't put my laptop down. I see, and that was 15 years ago. So definitely has sparked some real deep interest that I can't explain really, if I'm honest, but it sort of stems from people that I worked with.
Right, and to give listeners a context, Peter, to your week to week, what percentage of the time are you spending at the university? What's your role there, and what's your work like in your clinic, Complete Sports Care?
So I'm at the clinic 1 day a week these days, and then I'm at Monash University 4 days a week as an Associate Professor. And I'm very lucky here because I get to focus on the research, and I give one hour of lecturing per week to the undergrads, and that's on a research topic. And the rest of the time I'm in the lab, or I'm supervising students, or collecting data, or writing in regards to the tendon research that I do. So it's a good mix. I'm very fortunate. And
Peter, you're an active bloke yourself. I remember chatting with you there last year. You enjoy your running as well, right?
Yeah, I do. I would say I don't know if I describe myself as active. The people that I work with, the employees at our clinics, have got a very distinctive running gait, which is not a compliment.
well, Peter, let's talk about tendons. One question I certainly get in my work, as you would in your clinical work, from consumers of healthcare services or people suffering from tendon pain, is where does the pain actually come from? What's the underlying process that actually elicits pain in these tendons? And listeners, we're talking about lower limb tendons today, so typically the tendons we'd be dealing with are Achilles tendons, hamstring tendons up high near the bottom, quadriceps tendons, patellar tendons, and to a degree peroneal tendons. So these are all in the lower limb. But Peter, what actually produces this pain? Why are we feeling the pain when these things get sore?
Well, it's a good question. It's one that people have spent a lot of time trying to answer, and unfortunately we still don't have a good answer to that question about where the pain is coming from. And there's lots of different theories, but the theories probably can be summarised in two main groups, and that is theories that revolve around some sort of change in the structure of the tendon. So this idea that if you mechanically compromise, or you have some, maybe you've had a tear or something like that reported, could that be painful? But we know that that's probably not the case, and we know that structural pathology that we can see on imaging doesn't have a good relationship with pain at all, really. So that theory was one of the original ones, but has really been debunked now. And what we think is that the pain probably does come from the tendon, but it's more of a biochemical process. It's not quite an inflammatory process, but it may have some similarities to inflammation, but it's a biochemical process that sensitizes the tissue. And the best way to think about it, one of the things that I tell patients is, think about when you've had a bruise or a contusion. You've got that is an inflammatory process, but when you touch it, it's sore. The reason it's sore is because there's biochemicals in there that have sensitized local nerves, and that's why it's sore to touch. It's the same with the tendon. It's biochemicals that actually lead to that sensitization process, but most likely it involves many biochemicals, many that we don't even know about. So we don't really, I don't think we're anywhere near a full understanding, but we think that we know it's a biochemical rather than a structural pain. So one of the important distinctions for patients is that the pain they're feeling is not necessarily closely related to pathology and not necessarily closely related to damage.
Yeah, so isn't it I've been a practitioner practicing for 11 years, and I've seen the change, the evolution away from the old tendinitis model / explanation that, used to be so readily espoused through to, more of this line of thinking, which you just shared there, Peter. Just for listeners' benefit, the tendinitis model, when and how did that really get thrown out and debunked?
Probably about 15 years ago, people started to look at with some new techniques, lab techniques. They started to take biopsies from the tendon, and what they were finding is that the tissue they were sampling didn't have a high concentration of inflammatory markers or biochemicals. They've also looked with other techniques. So they've looked with a technique called microdialysis, which you put a catheter into a tendon, and it's what we call an in vivo technique. So you don't take the sample out of the body; you're sampling the actual body in someone that's active. And even with those techniques, they haven't been able to show that there's inflammation. But there is a bit of debate, and more recently, people have. It's almost like a pendulum. It's swung away from inflammation, but more recent studies are showing that maybe there are some similarities with the inflammatory process. So some of the biochemicals that we see in inflammation, we also see in chronic tendon problems. It's not an identical process to, say, if you sprain your ankle and you have an inflammatory healing process going on there, but there are some similarities. But certainly it's gone away, as you say, from that classic inflammatory model of, say, the 80s.
Yeah, and I mean the terms that the consumer, the average health consumer, is going to come across these days, Peter, or listeners of this program who are active, training for marathons and different things that we readily see reported on imaging these days, the terms tendinoses and tendinopathy. How would you define or describe a tendinosis / tendinopathy for the listener of this program, Peter?
Tendinopathy is a broad term that just means any pain or pathology in the tendon. So that's the broadest term, and that's the term that we use clinically because we really don't know clinically anything. We don't have anything but our clinical diagnostic and assessment skills. Sometimes we'll have imaging as well. Now, when you have imaging, you can see pathology in the tendon, and that's what we call tendinosis. So tendinosis means the pathology in the actual tendon. Now, if you haven't got any confirmation of that with imaging, then the general term is tendinopathy, which can mean anything that is affecting the tendon from a pain or pathology point of view.
Yeah, certainly. And Peter, with the tendinopathies, there's been models put forwards in the literature that have then found their way over to clinical practice around this continuum, if you like, of reactive type presentations where someone spikes their training load perhaps as a runner, for example, and experiences acute onset of, say, Achilles tendon pain, right through to the more grumbly long-term aggravated Achilles tendon of a runner, which might be deemed a more sort of, degenerative type presentation. But I know it's not that simple. But in terms of, for listeners, what's the spectrum that, you would expect to see in clinical practice? And can you give listeners a bit of an insight into the differences between the different types of presentations of these tendinopathies? Yeah,
look, I guess the important thing is to define if you're talking about pain or pathology. Because if you're talking about pathology, there are lots of models that sort of describe how the pathology comes on and how it progresses. And, the one you're talking about, the continuum, that's probably the most popular one, where they talk about initially you have just a bit of a thickening of the tendon, and then you sort of have a breakdown of some of the collagen, which is the strong, load-bearing material in the tendon. So that happens over time, and that's the sort of later stages. But what we know is that these pathology models can sometimes be confusing because they don't necessarily relate very well to what's happening from a pain point of view. So I'll give you an example. You might be having Achilles pain in your Achilles region. This is something I see a lot in clinical practice. You go to the GP or you go to the physio or the sports doctor, they do an ultrasound scan and they see that you've got this pathology in your tendon, and they might say, look, you've got tendinosis or you've got degenerative pathology, which is just another word for that end-stage broken down collagen pathology. But, your pain might be not coming from that pathology that they're found in the tendon. And so it's very important for clinicians to be able to assess someone from a clinical point of view, because we know that regardless of the pathology that someone has in their tendon, it may not necessarily be painful. And even if it's really severe pathology, that doesn't mean you have severe pain. Yep. So, there's a real disconnect between those two, and it's can be quite confusing for patients and also quite damaging if they're told, look, you've got this severe pathology or you've got these tears, but actually we know that doesn't really change your outcome, even if the pain is coming from those structures. So it's very confusing. It's one of the things that I spend a lot of time educating people about in the clinic.
Yeah, in terms of educating them, you're educating them about that, Peter, are you? That, the imaging doesn't equate necessarily to your pain, nor is it a good guide of your progress. Yet it's, it's one of the first things that is reached for in, I guess, trying to come to some sort of diagnosis. But you touched on that, your pain might not even be coming. A listener of this show the pain might not even be coming from a tendon. It might be coming from a surrounding structure, which is where I guess, Peter, the key is to be so carefully assessed and diagnosed, right?
Oh, absolutely. That's very true. So I always tell patients the pain may not be coming from, you can have pathology without pain. So that tells us in itself that the pathology itself is not the cause of the pain. It's, as we're talking about, these underlying biochemicals are more likely the cause. If you have worse pathology, it doesn't mean your outcome's going to be poorer. So, a lot of people come to the clinic and their doctors told them, look, you've got really quite severe pathology. That doesn't really mean that you're going to have a poorer outcome. Better if you have the right treatment.
Yeah.
And also the other thing is not to focus on the pathology, because we know that doesn't necessarily get better with treatment. So, one good example is PRP, which is platelet-rich plasma blood injections, which are really common. In the clinic, I only see patients who have failed lots of different treatments, including exercise and injections, and a lot of the people have come and they've had 4 or 5 PRP injections and they've spent, a fortune on them, and usually they haven't had any benefit. Or the ones I see, a biased sample anyway, they wouldn't be coming to see me if they had benefit. But yep. Basically, they promised healing of the tendon because, this model of look at the pathology, it needs to be healed. And it makes such intuitive sense to the patient to think, oh, yeah, that makes sense. I need PRP to heal this tendinosis that they've shown me on the. It's just, it really is rubbish. It just doesn't happen like that. You don't get the healing from those things. And the focus on the pathology is really not the right way to go. And
so your framework is to more focus on the function and the pain and the response on that basis. Is that correct?
Yeah, that's right. So you're looking at so if you look at the continuum model, again, it has 2 facets to it. It has a pathology, which we've talked about, the progression, but it also has a pain level to it, where you're grading pain from pain that doesn't really trouble people too much to pain that really flares up for a long time when they've done something and troubles them a lot. So when they're on the more, troubled end of the pain spectrum, then we do different things with them and we try and settle down that pain. But that's a good way to grade them in the clinic. The other good way to grade them is how functional they are. So you might look at, if you've got an Achilles, for example, you might look at their calf strength and see, how much strength have they got, and targeting those factors in your treatment is much more likely to lead to an effective outcome for the person.
Yeah, great. Well, let's talk about, Peter, some of what are the biggest I'd like to break down just to sort of at each tendon, just some key messages for the listeners to really take away and have some insights around. But before that, Peter, what are some of the main mistakes that you see, patients making in managing their tendons? What would be sort of the top 3 mistakes that you routinely see?
Probably the most important one is people not spending enough time on doing their exercises appropriately. So people will often be prescribed exercise and for whatever reason not adhere to it very well, or not spend the time doing it. And I think that comes down to the education that they're given by the people that are prescribing the exercise for them as well. So I think by far the most important reason why people don't respond to treatment is because they type of exercise, or they have had the right exercise given to them and the right advice, but they haven't done it appropriately. So that's what I see in the clinic. And then that leads to this sort of panic among clinicians and the patients to say, okay, so you've tried the exercise, that hasn't worked. So then we need to look at all these other options, all these injections and, orthotics and all these other things that they then start to look at, shockwave therapy. And that's just a response to not doing core things, and that is, educating people about how to manage and how to progress their load and how to do the exercise and doing the appropriate exercise. So I think by far that's the thing that I see in the clinic the most.
So Peter, it's interesting, that can start a whole rabbit warren of people panicking, as you say, practitioners alike, and chasing these hopeful solutions, whether it's PRP or shockwave or orthotics or the next thing, yet the very raw and key ingredients of some of the modalities of the exercise have just been missing, like it hasn't been done for long enough, or it's been the wrong exercise, or key progressions in the exercise rehabilitation have been left out. So I'd like to unpack some of the key things that need to happen, but we might do that sort of generally, and then look at sort of each tendon in isolation. So let's talk about the exercise progressions then, Peter. Tendons respond to time under load and to load, and certainly over my years as a practitioner, I've seen this shift away from good old Achilles tendon management, go drop your heel off the edge of a step, through to the introduction of what some listeners would know as these isometric exercises. And then your work, Peter, I've implemented in my own practice with success with the running population I look at, where it's imperative that they roll through the early stage work, isometrics, right through to jump in stuff, etc. at the end. So can you take us through as listeners the stages that you might, for example, take a classic, let's say an Achilles tendon through in terms of exercises? Yeah,
for sure. Look, it's I guess the important thing to say from a evidence point of view is that there's not, if you look at all the evidence, and there's lots in Achilles and Patellar, there's not any clear evidence that any particular exercise is better than the other. We have the Alfredson program over the step, as you described. You've got the isometric stuff, which is really popular at the moment. You've got even just some programs that just involve people going to the gym and doing heavy loading stuff in the gym. And if you look at comparisons between these programs, there's not really any clear favourite. And the messages we get out of that is that if you are able to just progress the exercise gradually, monitor the pain, make sure that you're not getting, a little bit of pain during the exercise is okay, but as long as it's not flaring the next day, you're progressing the load, you're doing it consistently, every day, every second day. I believe the load is an important part of it, so progressing, load and intensity. But we sort of start like that, and as you say, the isometrics that's just a static exercise where you're not moving, and that's sometimes a good way to start if people have a lot of pain and they can't, progress to some of the what we call isotonic, which is just, moving up and down. And isotonic would also include the eccentric type exercise, where people are going over a step. So that would be the next progression, going to movement exercise, and then finally you want to get them into things where they're replicating their sports load, so they're doing things like jumping and running, whatever it might be for the particular sport they're doing. So the sort of progression, and it's all based on pain. So it's all based on monitoring their symptoms and bringing things in when they're ready for it, based on their primarily their response to load. So there's nothing wrong with running, for example, if your symptoms during running are reasonably low. And sometimes we rate that as a sort of 2 or 3 out of 10. And the next day your symptoms don't markedly, increase with running, then that's not a problem. So the whole progression through that rehab is based on pain. Now, obviously, in parallel to that, if you're seeing a good physio, they should also be looking at, is your strength getting better as well? Because by the time you get back to full sport or full running demands, you want to make sure that you've worked your strength up as well. And the functional part of it is also important.
And that strength, Peter, isn't just in the case of an Achilles tendon getting a stronger calf, or the soleus, muscle which sits at the back of the leg there. It's also, the term we use obviously as clinicians is the kinetic chain. But, it's the rest of the body, right, Peter?
Yeah, that's right, exactly. So we usually make sure that we give something for, if you're seeing, say, someone with a hamstring tendon problem, you'd still look at their knee and their ankle and their function around that, and especially you tie that into the previous injuries they've had. So they might have had, for example, an ankle injury on one side, and then they've got this hamstring injury on the other side. So you want to see if they've got any functional deficits and if that's relevant at all.
And Peter, I've heard you share around in the example of a patellar tendon, linking in this idea of strengthening not just the local area but the whole kinetic chain, the whole body there. I've heard you share around the patellar tendon strength paradox. Can you, in the case of, say, a patellar tendon that's been sore for some time, maybe 6 months, can you give listeners an example of how quite bizarre the body can respond in terms of what gets strong and what gets weak?
Yep. So basically, what we know, one of the things that happens with a tendon problem is the local muscle tendon unit, because it's painful, the body tries to shut it down a bit. So you don't have as much, it's almost, you can think of it as a neurological problem. The brain tries not to use the part that's affected, which is a good short-term strategy because it allows things to not be as painful and to hopefully overcome the overload and the pain that they've got. But so the paradox would be that you can still get someone who can jump fairly well, but they're probably largely using other parts of their kinetic chain to do that. So one of the things we believe in a lot is looking at the isolated strength and function of the kinetic chain, and then looking at the whole strength and function. So you asked about things that people before. One of the real important things is, which you'd remember from the course, because I tend to go on about it a lot, is not enough isolated assessment. So you take patellar tendon, you might look at someone in the leg extension, which is an isolated test and they're really weak. Then you look at them in a leg press or a squat, which is a compound multi-joint task, and then their strength is okay. And that's this sort of compensation thing going on.
Yeah, and I find it clinically fascinating just how, for want of a better word, weak muscles, for example, the quads with patellar tendon or the hamstrings for high hamstring tendon problems can get, where people can be back running, yet they struggle to do a hamstring curl isolated with even, say, 4 or 5 kilos. It's amazing how the body can still carry on, yet there's such a deficit through this inhibition of the pain from the tendon.
Absolutely, I would definitely agree with that. It's really it's a common finding. It's a really common finding, unfortunately. And I think it's because, and whenever I lecture physios and do courses, I always say to them as a joke, but I'm sort of half serious, that in your clinic you sort of need the capacity to function like an isolate, like a leg curl for a hamstring or a leg extension for a patella, because it's just so common, as you say, to get someone who is running but can't do a hamstring curl. So it's a concern.
And it's certainly been, in the bigger, wider picture of health and fitness, a trend away from, the isolated exercises that maybe got done in the 80s in gyms. It's hard to find a seated calf raise machine these days, and sometimes a prone hamstring curl machine, yet in the rehab context, they can be so useful. I often struggle to get patients finding gyms that sometimes have the equipment necessary to do some of the required rehabilitation. Do you find that as well?
You're right, I find that commonly. I also find the attitude of some practitioners out there is a barrier doing it, because I had a patient recently who's a 75-year-old lady who she was athletic, she was still playing tennis, and she's still playing her doubles a couple of times a week, and she wanted to get. She's got an Achilles problem, and when I assessed her, she couldn't do a single leg calf raise, and so she was going to this local gym, and I called the person. I said, "Can you please get her onto the single leg calf raise, seated calf raise?" And he didn't want to do it. He said, "No, that's not appropriate for someone of her age to be doing that type of exercise, that isolated exercise. She needs general strength." So I think the attitude of some people can be a barrier, which is unfortunate. So I've got her in the clinic now for the last 2 months. This is our one, and she's much better. She's able to do a single leg calf raise now. Not back to tennis yet, but she's much better. So this is it's disappointing that you do get very polarised views in that people would say you definitely shouldn't do anything isolated. It's all about compound and functional things.
Yeah, and I like to make the differentiation. We're talking about rehabilitation here. We can talk about the functional stuff to a larger degree once you're further down your rehabilitation route. But if your listeners, you're finding a bit of resistance in terms of getting equipment, etc., stay resourceful and stay the course, because as I often say to patients, Peter, look, this can be a long haul, but if you're looking to get back to the things that you love to do, then you've just got to stay the course. Otherwise, it's not going to happen for you. How do you instill that I guess resilience, that tenacity, if you like, or some hope in some patients that, as you say, you don't see patients typically in your limited clinical availability that have just flared up with a tendon problem. These people might have been through 4 or 5 practitioners that end up on your door, often maybe as the last sort of hope to come in to see you. What key messages do you share with patients like that have lost hope, that you can sort of reinstore some confidence?
I think one of the things that works really well is to show them deficits or issues that they have that other people haven't picked up. So again, if you do a thorough assessment and you're looking at your isolated stuff or things that are just assessments that people haven't looked at, that is a real good message for them. So last night I was in the clinic and I worked till 8 o'clock, and my last patient from 7 till 8 was a new Achilles lady who's had it for 3 years, and she wants to return to running, hasn't been able to run for at least a year, and she was very much of the opinion that she'd tried all the exercise that was out there and that wasn't going to help her, which is a lot of my patients actually. So I think I've become reasonably good at trying to convince people that there are still issues, and all I did for her was take her into the seated calf raise machine in our clinic and get her to do one side versus the other, and she could see not only the difference in strength but also control if you get them to do it properly. And once they can see that they've got a problem, it's much easier to convince them that you can show them a pathway of doing something new that might help them. But when I looked at her calf raises, which everyone else has told her to do, there was no difference side to side, because she's been doing that for a long time and it hasn't helped her. So I didn't give her that to do, because she's already tried that and failed it. So I think you've got to find something that I think you've got to find a way of really breaking into their beliefs of, changing their beliefs of, this is not going to work for me because I've tried it. And the best way is to show them that what you're offering is different.
Yeah. So looking, as you say, for those, insights that they, things that other practitioners or other
therapists may not have picked up that immediately show them that you're onto something different. And you can't argue with the experience, right? You can argue with the theory, but not the experience when you ask someone to perform a strength test and they can clearly see the difference.
Yeah, exactly right. And it's not always, I must point out, it's not always that easy, because sometimes you do all your strength stuff and there's nothing that other people have missed, and maybe it's just that they're, something else has been a barrier, like their adherence or something else, and then you've got to convince them of that. So it's not always possible to show them a functional deficit.
Peter, is there one, without obviously revealing patient identity, but one case in particular that over all your years of focusing on in this line of work, lower limb tendinopathies, that really stands out as a surprise that they got the result that they did from your end as a clinician? This is, I guess, to inspire or encourage listeners that may feel like they're stuck in this never-ending stage of pain that they're getting from a tendon injury, and maybe they're having to sit on the sideline or frustrated with reduced running, for example. Is there one story where you're like, what, that's my benchmark? If Mrs. Jones could get back, there's hope for anyone with a lower limb tendon problem?
Yeah, I think the most rewarding ones are the ones that have been very long term, and I can think, and particularly Patellar tendons that I've seen over the years that have been very long term, in that they've tried everything. And there was one person who had tried everything, all the injections and surgery, and then we basically started from scratch again, because he hadn't done an appropriate rehab intervention. So you're looking at it sort of, overall of sort of 3 or 4 year ordeal for him, but he's back to doing what he loves, which is AFL umpiring. Another person that I recently saw was an elite tennis player, and he was also Patellar tendon, and he also had a 3 or 4 year ordeal. He got it when he was 17, and excuse me, I started seeing him when he was 19, and he's just got better, and he's 21 now. So it took me 2 years to get him better.
Wow. But he's, as you say, back to doing what he loves. And, what was his alternative, Peter? What would have happened if he hadn't have come across you, like for patients like this?
Well, he could have arguably the next thing would have been surgery for him, but he's happy. He's gone through, it took a long, long time, and there was lots of things we had to address with him. But fortunately, he's back to playing tennis, and he's doing well. But it does take time. But I firmly believe that if you put in the effort and the time, and you get the right advice, you can get over any tendon problem. One thing I've started doing a lot these days is Skype consults. So I do Skype consults, people overseas and also here sometimes with their local physios, and and I find you can still get people better that have had a long history, even that way, if their issue is really related around not having the right advice, which is quite common.
Yeah, it's interesting. And telehealth, I do a few Skype consults as well, Peter, with runners. That's my niche in practice. And as you say, you can make a true difference sitting remotely, just not touching the patient, not physically assessing them. You can do some assessment online, but as you say, often just with those key directional inputs in terms of their next steps through advice alone. It's such a big area. Peter, you mentioned surgery there. There's such a general fear of surgery, rightfully or wrongfully. It's obviously always contextual to the individual's journey and case. But as a practitioner, what are your sort of views on surgery when it comes to tendons? And I know this is like how long's a bit of string, but what are some of the key messages you think would be important for listeners to know about surgery when it comes to tendons?
I think the most important one is to make sure you explore all the options before. The surgery is really a last resort, and the evidence is not very good that for surgery we don't have many studies that look at the outcomes of surgery in good quality studies. I'll give you an example of one that was presented at the Sports Medicine Conference in Australia last year, and they looked at tennis elbow surgery versus sham or placebo tennis elbow surgery, and they found there was no difference between them in outcome. So, it's really important. I'm not saying surgery is a placebo only, but what I am saying is that people can get better without surgery, is my opinion. A vast majority can get better without surgery. And I think most good tendon surgeons would agree with that. You just need to follow the principles and be a bit patient. And the problem with elite sport is that people aren't patient, and that's why you tend to have lots of people having surgery for tendon pain in elite sport, or in sport in general.
And when it comes to what they're actually doing to the tendon in some of these surgical procedures, what would a surgeon actually be doing, Peter?
What they used to do was cut into it and try and get a sort of reaction and a big fibrotic type response. And what they do these days is they tend to leave the tendon alone, and they just strip all the surrounding tissues and the fat pad and the parotinon and all the vessels growing into the tendon, and that's a much better option, because you don't have the long-term sort of recovery that you would with a tenotomy. With a stripping of the tendon, it's going to take you at least 12 months to get back to full function.
Yeah. So, listeners, if you are out there struggling with a tendon injury, as Peter said, be sure to explore all options thoroughly first. You mentioned, Peter, earlier the role of the brain in pain. At your lower limb tendinopathy course that I referenced earlier, we watched a great little YouTube clip, which listeners will link up in the show notes, but the backwards bicycle experiment, which I really enjoyed. Peter, what role does the brain play in these tendon presentations?
It can have quite a big role for some people. It's important to appreciate that the brain is a filter, and it will filter everything coming from your periphery in terms of messages. We know there's no such thing as a pain receptor in the tissue. We just have messages coming from the tissues, and it's the brain's job to interpret that as dangerous or threatening, in which case an output might be pain. So the brain is critical in pain. That's not to say that it's all in your head and there's no such thing as tendon pain. I think there is something biochemical happening in the tissue. But for some people, they can go to the extreme of the brain really driving their symptoms or modulating or really changing their symptoms to the point where it's a key feature for them. And often we see this with people that have had it for a bit longer, and the pain becomes a bit different. It's not so related to the load or activity they do, and sometimes it becomes a bit more spreading, and they can have pain that changes and shifts, and all these things we sort of relate to someone who's got a changing type of pain presentation. And then you've got people that are just very, very attentive to it, and that stress and anxiety and attention can also make change the pain experience.
Yeah, so there's a few layers there, Peter, but I think it's important to note that being informed and educated with the correct processes is going to make the world of difference in terms of some of that, as we know it in clinical land, potential sensitization of the process correct. So I think that's where getting the right information early and upfront is so important, right? And you talk about education being such a key component of rehabilitation.
Yep, absolutely.
Any other key educational messages, Peter, that you feel it's important for listeners to know? We've spoken about the fact that imaging doesn't always match up with pain. We've touched on the potential role of some of the pressures and stresses and anxieties can have on rehabilitation outcomes. What are some of the other key educational messages you think are important, Peter?
I think the main one is to have the patient have clear in their mind that their pain is not damaging. Most likely, well, they need to hear that from an expert or from a trained person. But someone assesses them and tells them that, look, you've got this tendinopathy, it's chronic tendon pain. It's unlikely to be related to damage or pathology. That's a key message. So those messages around pathology that we talked about, that pathology doesn't dictate your outcome, is another message. The messages about exercise and how exercise works, I think, are very important. So the patient needs to understand that they're not just strengthening, they're not just doing exercise to get stronger or get more functional. It's more about trying to change their pain perception and have an influence on their, what I call their threshold or their pain tolerance. That's a key message, because that tells them about how to, it really tells them about how to progress and regress their pain, which is also another key message. So you need to empower them to self-manage and to know that this pain is acceptable, this pain is not acceptable. Telling them about how their pain will fluctuate during the rehab, and how pain flaring up is normal, but as long as it recovers quickly. So those messages, I think, are really key.
Peter, thanks for sharing that. They're brilliant tips, listeners, so thank you, Peter. Just getting really practical in terms of each of the tendon areas that listeners have likely experienced pain in at some point in their active lifespans. And I know this is difficult as a clinician, Peter, because I'm not setting you up with a case study. I'm just asking you to give some practical tips. What are a couple of key practical tips for each of the regions, starting with Achilles? So maybe to give you some context, let's talk about someone that's acutely flared up, not someone that's had this for 2 years, but they've kind of just developed pain in their Achilles tendons. Are there any quick wins that they can implement that can help them?
In the short term, the important thing is to try and modify your load. So if you're running, reduce the running, but only as much as is needed, and as much as is needed is to the point where you're not flaring up from the running. So try and find that balance, that set point that your body will allow you to tolerate. Don't give the running away completely. That's what I find with a lot of people. There's two reactions to pain with Achilles. Either they run through it, and that's not good, or that can be not good, or they just stop and shut down completely, and that's also not good. So you've got to try and find the balance of what your body will allow you to tolerate. And the likelihood is that most patients, when they do that, that's all they do, and they'll get better. But then if you want to take it more clinical, you could then start thinking about things like applying a bit of exercise to increase your load tolerance based on the principles that we've talked about. But then there's all the little helpers, what I call the helpers, like looking at your shoes or a heel wedge or a bit of tape, things like that can help smooth over that little increase in pain.
Yeah, brilliant. And Peter, what about the Patellar Tendon? So for listeners, that's the bit between the kneecap and the knobbly little bit on the front of your shin bone, if you like. What are some key little quick wins or helpers for Patellar Tendon problems that have just...
Patellar tendon, it's usually... It's not that common in people that are running only. Usually you get it in people who are sprinting or doing jumping sports. And the main thing for them is to look at things. In terms of quick wins, we sometimes apply tape. So tape or a brace to the patella, which can help their pain in the short term. But really you want to look at how those people are jumping or sprinting. You want to look at their biomechanics, because it's very much a load-related problem, and you want to try and optimize how they're absorbing load through their patellar tendon and through their whole kinetic chain. I'll give you an example. You see it a lot in footballers, and they will go up for a mark and take the mark and then land, and they don't use their hips at all to absorb load. So they're really forcing a lot of load on their knee. So you can change that with some simple retraining.
Yeah, powerful. Something simple, as you say. I remember as a physio student, Peter, at the AIS, one of my projects was to look at the incidence of patellar tendon problems in the basketballers, the women's basketball team, and I had to observe quite a few hours of footage and look at and categorise their landing, as you just outlined. Was it, is there anything happening at the hip, or was it all happening at the knee? So simple things like that. That's really good, Peter. What about proximal hamstring up in near the buttock there? This is the pain that people get when they sit down. And any quick wins there, helpers?
I guess the best quick win for that is to look at your cadence in running, because we know the hammy really doesn't like when it is out on stretch with very long stride length, and that obviously happens when you're sprinting. It's going to have to happen when you're sprinting, because you have to increase your stride length and your step rate as you run faster. But if you're running at a moderate speed, then just fasten your step rate and reduce your stride length, which will really take a lot of load off the hamstring. And if you've got walking people that are listening, just walk slower or with smaller steps, because we know that walking fast is actually higher load for the hamstring than running very slow.
Yeah, fascinating. Who would have thought, hey? The peroneal tendon, the peroneal tendon's up the side of the leg there, Peter. These are probably a little bit less common and, commonly seen, maybe not in practice, but experienced out there by the listeners. So any quick wins for that type of tendon pain?
Not one that I see a lot, to be honest, but in my experience, there's a lot. It's very biomechanical rather than it's sort of, you've got to look at the biomechanics of the foot. And there is, it's about load tolerance and increasing the loading of it, as we've talked about. But in my experience, biomechanics of the foot, so it's one that you want to get a good opinion from someone about your biomechanics around the foot.
Yeah, okay, great. Peter, I appreciate our time's almost coming to a close, but a couple of key topics I just want to touch on. One is tips for return to running. This is an area I certainly spend a lot of time giving advice around and guidance around. What are your key tips for, in the case of runners or people returning to running even recreationally, to get return to running protocols right?
I think the best one is just start at the right time. So have some sort of measure or criteria that is going to, so if you've stopped running, I guess actually before we go into that, the most important one is don't stop if you can afford to. So if you can find that level, as we talked about, where you're not needing to stop, and that's ideal. But if you have been forced to stop, you really needed a break, because you just, every time you run, you just flare up and you're a lot worse. Try and minimise the time of that break. And when you're getting back, have some sort of criteria. So the criteria usually is some sort of provocative test. And I take the patients through, so for example, in Achilles, you might do some hopping and jumping and pick the one that's most painful. And with all your treatments and your exercise, once that pain with that provocative test gets to a good level, that's a good indication that you can start to run again.
Yeah, great. And the best way to monitor the pain response to return to running would be what, Peter?
Again, just look at a load test, and you can look at say the next day. How do you feel on a test that brings on a bit of pain for you? So it might be doing again some hopping or something like that, where you think, okay, and this is this concept of acceptable pain. People need to then sort of take on, okay, this is my baseline. When I hop, my pain's 2 out of 10, and likely that's going to stay there for the next little while whilst I increase my running. As long as it doesn't increase, I'm happy.
Yeah, okay, great. Peter, anti-inflammatories and shockwave therapy. Anti-inflammatories first. I know maybe a decade plus ago there was almost some resistance or concern about anti-inflammatory use with some tendon conditions, fear of delay in healing, etc. Can you speak to the current context of anti-inflammatories in the management of tendon problems?
Yeah, there's not anything to tell us that we shouldn't be using them necessarily. They probably give you short-term relief from pain. It's not known whether they offer anything more than that from a point of view of actual healing, because, as we said, there may be some elements of an inflammatory sort of process going on, but not a full-blown inflammatory process as we have in other areas. So my take on it is you could probably take either paracetamol or anti-inflammatories and possibly get the same response. But it's unknown whether the anti-inflammatories offer anything more at this point. But if you haven't got any risks of taking them, you may as well take the anti-inflammatories.
Got it. So there's nothing to be fearful of if it's done at the right time and in the right fashion, right?
Yeah, absolutely.
Shockwave therapy, Peter. I know you have done research in this capacity. I know you use it in the clinic, but I also appreciate and know that you know its limitations as well. So for listeners that maybe thinking of shockwave therapy or have had shockwave therapy, and any key learnings you've taken from your time using that as a modality?
It's a good pain modulator, so it's just got to make sure that it's offered in the right context. It's never going to be something, I believe, that is going to be effective at treating your tendon pain in isolation. It's something that you would do in combination with right advice, and can be helpful in reducing your pain in the short term to allow things in the rehabilitation to go a bit smoother and a bit faster.
Yeah, okay, great. So it's not going to be the magic pill, is it? The magic bullet?
Unfortunately, there's no such thing.
Yeah. And cortisone, Peter, there's a bit of a stigma and, sometimes a false, attribution bias to cortisone being the solution. Your views on cortisone in therapies of tendons?
Yeah, I think if you look at, there's good evidence that if you have cortisone, then the pain tends to be much better for a few weeks, and then it comes back again. And we know that from lots of studies in lots of different tendons. So certainly it's a short-term way of improving pain, and you could probably argue it based on that as a once-off, but we know that if you do lots of steroid, you can get tendon ruptures, or you can get other things like the pain often becomes worse if you've had too much steroid. So we see that clinically as well. So I think you've got to be very careful and just limit the amount of steroid you have. And my advice to patients is, if you can avoid it, avoid it.
Yeah, great. Peter, if you could boil down your years of research, your years of clinical experience, I'm going to put you on the spot here, Peter.
Yep.
You're a smart guy. I know you'll pull through. Into one bit of advice you would give, if you could only give one bit of advice to people suffering from tendon conditions, frustrated because they're not out there doing the things they love, potentially fearful that they won't ever return to the things they love. If you could give one bit of advice, Dr. Peter Malliaras, what would it be?
It's a tough one, I would say, because it's a tough one because I'm learning all the time, and things are changing all the time. But I think the one consistent thing is do your exercises very well. Focus on quality and focus on getting the exercise done well, and try and understand your condition. The only person that can get your tendon better is you, not any doctor who's promising injections or surgery, or any physio who's promising any sort of other techniques. Or the only person that can really get your tendon better is you, and you need to understand it and get good advice about it, and that's the way to get it better.
Dr. Peter Malliaras, if listeners want to find out more, potentially access your services or certainly access your information, where can listeners find that, Peter?
So my clinic is Complete Sports Care in Melbourne, and completesportscare.com.au, and I've got a blog, Tendinopathy blog, which is just tendinopathy.rehab.com. But it's pretty much it. And Twitter and all that sort of stuff as well.
And listeners, we'll link up all of these URLs and also Peter's social media handle, which is at Dr. Peter Malliaras on Twitter, in the show notes. So jump over there to access those links directly. And Dr. Peter, we like to finish with the guest issuing the listeners one physical challenge for the week. It can be very hard or it can be very easy, just to instill a bit of physical activity and challenge. What would yours be?
Try and stand up all day when you're working if you've got a sitting job.
So take the stand-up challenge.
Stand up desk. Stand up desk, that's right.
Fantastic. I'm recording this on a stand-up desk, Peter, so I'm ticking the challenge early.
I'm actually sitting on my standing desk.
Oh, mate, there you go. Peter, really appreciate your time. Thanks for the meaningful contribution you make to so many through the work that you do. I'm just one of many beneficiaries of what you do.
I would say it's a very modest contribution, but thank you. Thank you very much, Brad.
So there you have it, another episode of the Physical Performance Show, and the program's first expert, Dr. Peter Malliaras, sharing around the management of tendon pain and problems. So if you did enjoy that, please let Dr. Peter Malliaras and myself know. You'll find our social media handles over on the show notes, or at the show notes, pogophysio.com.au. and let us know what you took away from it. Pass it on, share it with anyone that you know that's struggling with a tendon problem, and we'd both really appreciate that. A massive thank you, as always, to the two very good folk who bring this, the Physical Performance Show, to you, and that is Mr. Daryl Misson, audio engineer, and Susan Wilkin, the show's VA. Thank you mightily to you both. Guys, if you'd like to get the podcast into your ears each and every week as the episodes go live, be sure to simply hit subscribe from within your app, and that'll automatically populate it into your device for hopefully your listening pleasure and your listening interest. Lastly, if you're into running, you can now pick up your copy of my Amazon running and jogging bestseller, You Can Run Pain Free. It's available over on Audible or iBooks now, so you can tune in and enjoy the learnings of discovering how to run without injury and also faster through getting it into your earbuds as you're on the move. It's also available in typical traditional versions, digitally over via Amazon, or the paperback version through both Amazon and POGO Physio, shipping internationally, of course, through Amazon. Coming up on next week's episode of the Physical Performance Show, I catch up with British triathlon legend Spencer Smith. Spencer was the 93 and 94 World Triathlon Championship, and he had a really long and illustrious career through the 90s. And this is a rare glimpse into the behind the scenes of Spencer's world through his 2 decades really of international triathlon dominance. He shares around growing up, pursuing triathlon. He shares around the close bond that he had with his father and the great loss that he felt with his father's early passing. He shares around his first outing with the triathlon big dance, the Kona Hawaii Ironman triathlon champs. And he shares some brilliant coaching insights and tips. That's now Spencer's main focus, alongside a Burgundy clothing brand, which he mentions through the interview, and that is coaching. So you're going to really enjoy Spencer Smith, British triathlon great, sharing around the ins and outs, the highs and the lows of his career. So be sure to tune in next week to the Physical Performance Show. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.